Right. Welcome back to the Wellness Growth Show. Today we're with Dr. Xina Quan, CEO of PyrAmes. They built a continuous non-invasive blood pressure monitor for our most fragile patients, starting in the NICU. So think second by second blood pressure trends without an arterial line sustained over days. We'll unpack what that unlocks for nurses and neonatologists, how hospitals evaluate something truly new, and where this goes next. Welcome.
Thank you.
Yeah,
Appreciate the opportunity.
yes, thanks for being here. So, in one or two sentences, what does Paramus Health do and who benefits first?
So we make wearable blood pressure monitors that are comfortable and easy to use. Our first product is designed for babies in the NICU, starting with little 1 pound premature babies.
Ah. So, and then what problem did you set out to solve, and what gap did you see between cuffs and arterial lines?
So it's surprisingly hard to take good, accurate blood pressure measurements. There are two standards of care today. One of them is to use an inflatable cuff, like you use in the doctor's office, and the other is to insert a catheter into the artery. Cuffs only provide the spot check in time, but the art lines are the gold standard for blood pressure monitoring, but they're invasive, painful, and expensive.
Okay. So for listeners new to NICU care, what's an arterial line? And when is it necessary? And why does avoiding it matter in tiny babies?
Sorry about that. An arterial catheter, our arterial line is a catheter. It's actually inserted into the artery and it directly measures blood pressure. You use it when you have a patient who you think might have unstable blood pressure measurements or blood pressure. And so the real fear for little kids is that their blood pressure will drop really fast. And so then that leads to multi-organ failure. And the problem is it's really hard to put it in tiny babies who have really small arteries, and so they're more prone to complications.
Good. So we're trying to avoid that for sure.
Absolutely.
How does a wearable deliver a reliable blood pressure trend without an arterial line? And why is that clinically meaningful at the bedside?
So our device, this is our the device that we have FDA cleared, and so it just goes on the arm or the leg of the child. You don't actually have to insert anything into it, and it just lightly touches the skin. And so it allows you to have second by second values, um, which is similar to what you would get with an arterial catheter, but without the complications.
What's clear today and what's next in terms of patient populations or weight ranges?
So our first product, the Boppli, has been cleared for critically ill infants up to 5 kilograms in weight. We're developing new algorithms now that we plan to submit early next year, which will allow us to go up to 10 kilograms. And we've also been working on similar solutions for older children and adults.
Which one or two complications are you aiming to reduce by avoiding these arterial lines in these fragile patients?
Well, the biggest ones are that you've made a hole in someone's artery so they can have bleeding or they can have infections. And one problem in particular with small children is that since arteries are so small, you may have blood flow reduction downstream from the catheter. And so that can lead to major tissue damage, which can lead to amputations.
Okay. Could you share a brief example, like where does continuous BP data change like a clinical decision?
Oh, one of the cases that we had in a recent pilot study was Boppli was on a baby who was recovering from an operation, and they were trying to wean him off of his painkillers. And the nurse realized that Boppli measurement, the blood pressure appeared to be rising pretty fast. And when she checked, she decided that apparently the baby was in a lot of pain because of the loss of the pain medication. And she wouldn't have known that because the cuff measurement wasn't scheduled for another couple hours.
Oh, goodness. Whew. That's a that's a great example. So
Yes.
at the bedside, what does a nurse actually do differently versus cuffs or art lines?
The nice thing about our device is you can put it on the baby, anybody can put it on and get data within a few minutes. Whereas with a cuff, Quite often, you have to put it and the nurse will wake up the baby, put it on the cuff, and then wait until the baby has calmed down again enough to take the measurement. And that sometimes can take, 10 or 15 minutes at the nurse's time. And then an art line is even worse because you have to have someone who's been specially trained in how to put the art line in. And sometimes that could lead to a couple hours delay. And sometimes it's very difficult to find the artery. So you have to wait for an ultrasound team to come and locate the artery. You may need to have an x ray team come to make sure you put the catheter in the right place. And so it can be a very big production involving many people and a lot of time and cost.
Sounds like less stress for the baby too, and
Oh,
whoever's doing this for the
absolutely.
nurse.
One
Yeah.
of the things the nurses have really liked is that they could put it on and they could just leave it on the baby for hours at a time. So the baby can sleep through it and they can still see the measurements.
Without disturbing, waking them up, or
Exactly.
that sounds so much better. So economically, where does this fit in NICU operations? Length of stay or adverse events avoided, nurse time, kind of at high level.
So many of the hospitals we've been working with view this as a good alternative to either cuffs or art lines, depending on the patient. And it gives them an option where they don't want to take the risk of putting in an invasive arterial catheter, but they still need a reasonable amount of number of blood pressure measurements. Some of them view it as a transition where they would like to be able to pull an arterial catheter out sooner, but they can still collect it later, or that they can't find the team to put the art line in place. And so then they get coverage until that point. So there are a lot of potential applications that hospitals have considered. And one of the things that's surprised us once we started offering the device commercially was that the nurses really like it because it doesn't make the baby mad. They can put it on and it doesn't take them any effort to settle the baby again.
Imagine a day like that. That's great. So inside the hospital, who usually champions an evaluation, and what does a typical 1 week trial look like?
So for every hospital has their own pattern. By and large, new technology decision like this is done, needs to be championed from inside the hospital by either the nurses or the clinic or the neonatologists. But then it has to go to a value committee who evaluates it for the value to the hospital, the safety and efficacy. They look at the workflow to make sure it doesn't interrupt the nurse's day. So most places, what they've done is they've asked us to do a pilot evaluation, and our standard is a 1 week trial where we will come in, we'll put it on as many patients as they want, whichever types of patients they're most worried about being able to get these measurements with. And then at the end of the week, we have them fill out surveys. We have them caucus all the nurses who have used our device. We provide the data back for them to see how we compared and the type of coverage they got.
And I guess too, kind of just like, how did they feel? Like, did it help them? Did they see an improvement with their
Right.
patients? Did like maybe less stress on their end as well? I can't
We
imagine.
asked them how they liked it and also what features that they would like to see, sort of in future incarnations to make it even better for them.
Sure. No, that's great. That's valuable feedback. Okay. What what tends to shorten approval, and what reliably like slows it down without getting into confidential committee details?
Oh gosh, I really wish I knew. In most hospitals, it seems that where we've done the best, where we have a really enthusiastic set of champions who are very well connected to their value committees and they can make the case for us. In other cases, we just find that we get sort of stuck someplace in the administrative process and nobody's quite sure about who can say yes. Um, but having a good champion in there really does help move things forward.
Sure, sure. Okay. So outside the NICU, what are CVICU teams asking for that's like distinct from the neonatology?
So CVICUs are the cardiac wards where almost every kid in there is likely to get an arterial catheter. Um, as just part of the standard of care. They're still interested because they'd like to be able to pull the catheter out sooner. So they're more strictly a transitional play. Whereas in standard NICUs, there are a lot of patients they wouldn't put a art line in. And so we'd be looking at using Boppli for a lot of different types of conditions in those cases.
Okay. Where does the data live today? Bedside only or also in monitoring, like EMR systems?
So, our current product, our data gets transmitted wirelessly to a bedside device that we provide. But we do have a solution where we could tie our bedside device to a Philips bedside monitor. And then our data gets mirrored there and it gets transmitted to their EHR, which however they transfer data from the Philips there. We're working on similar solutions for other companies now as well.
That's great. Okay. What's the long term vision here?
We'd like to see more facilities adopt the Boppli for regular clinical use. We've learned a lot from each site that has used it, and they've helped us make the Boppli better and better. Seeing it used on a broader range of patients will help provide better care for all of them. We'd also like to start spreading into adjacent spaces, not just the CVICU and PICU with bigger kids, but also places where there are resource constraints that make it tough today to get either cuff measurements or put an art line in place, such as emergency care and transport care. We're seeing interest as well from places like cath labs and anesthesiologists for surgery. So our dream is to someday make blood pressure measurements as easy and ubiquitous as pulse ox is today.
Love it. So, for nurse leaders listening, what's the one message you want them to hear from you directly?
There's a new way to get continuous, non-invasive, and accurate blood pressure measurements, and would love to help you get blood pressure monitoring that your patients need.
If an NICU leader wants to evaluate this, what's the first internal step they should take?
Please talk to us. Would love to learn more about your needs. Would love to learn about your clinical focus and challenges. And we can talk about the value that other people have said that the Bopley provides. If you feel that the Bopley would be a good fit, we can walk you through the planning process and plan an awesome no cost pilot evaluation for you.
Okay, thanks so much for this. Okay. So if you're an EQ or CVICU leader and want to evaluate continuous non-invasive blood pressure monitoring, check out the show notes for contact details. Champions matter, especially nursing leadership. So share this episode with your value committee or your nurse manager to start the process. Thank you so much for listening. Really appreciate you on this call today. Thanks for tuning in to this episode of The Wellness Growth Show. If today's conversation sparked something for you, hit subscribe so you don't miss the stories, strategies, and insights from the front lines of wellness innovation. If you're a founder, operator, or health leader exploring growth into institutional markets and have a story worth telling, I'd love to hear from you. Reach out directly on LinkedIn or YouTube. And if you found this valuable, share it with a peer or post it online. You never know who needs to hear it. Until next time, stay well, keep moving, and keep building what matters.